Fabulous.
Yeah. Yes.
All right, good afternoon. Good afternoon. My name is Won-Ha Kim, and as the director of the Institute for Health Policy and Leadership, I want to welcome all of you to our Spotlight in Health Policy event. And I have the distinct pleasure of welcoming our speaker and introducing our speaker, Dr. Hector Flores. So he attended Stanford University and UC Davis School of Medicine, and upon graduation received the Henry J. Kaiser Family Foundation National Merit Award in recognition of his academic excellence and commitment to social medicine. And then he went on to complete his residency in family medicine in Kaiser Permanente, LA. And currently he serves as the founding member and co-director of the White Memorial Medical Center Family Medicine Residency Program in LA. The residency program was established in 1988 with the express purpose of providing a high-quality education to prepare physicians for practice in shortage areas and to contribute to diversity in the health professions. He also serves as chairman of the Department of Family Medicine at Adventist Health White Memorial, and he's the medical director of the Family Care Specialist Medical Group and FCS IPA, which collectively serves approximately 30,000 beneficiaries composed of Medi-Cal, Medicare, and commercial coverage, and 8% who are uninsured. He also sits in a lot of boards, so some of them are, he is a member of the Blue Shield of California Board of Directors, member of the California Endowment Board of Directors, member of LA County Medical Association Board of Directors, and most importantly for this talk, member of the California Future Health Workforce Commission. So, and he's gotten numerous awards, but it will take me too much time to list them all. So without further ado, please join me in welcoming Dr. Flores.
My charge for today is to kind of share a little bit about our experience in medical education, particularly because of the board opportunities that I've had to get kind of a global view of where workforce competencies and distribution are going to be needed looking to the future. And secondly, the California Commission's work on gaps in clinician supply. I'm going to talk mainly about physicians, but clearly this involves all other clinicians, PAs, nurse practitioners, nurse midwives, behavioral scientists, and other health professions. But for the interest of time, I'll focus on the physician component. So let's kind of get to it. What I wanted to do is maybe frame a little bit of where medical education needs to go, or at least from our perspective, given the pressures that we're facing in America. A lot of it is part of the election process now and the debates that are going on. And secondly, to talk about the role of workforce in that area in particular, and what the projected shortages are. And then lastly, the opportunities for all of us in medical education, particularly financial opportunities that I think will provide the resources we need to do the work. And coming from the perspective of the Blue Shield of California board, I know that health plans are now really serious about making investments in medical education. If nothing else, the network model HMOs, because they're competing with Kaiser, and Kaiser's eating our lunch, right? So we need to make sure we understand how to compete effectively with them. So let me start off with what folks often refer to as the burning platform in the US and the challenges we have. In 2017, we spent $3.5 trillion in healthcare. You may have seen the recent articles in this week's JAMA around waste and inefficiency. But they really point to that we have anywhere between $800 billion and $1 trillion out of that 3.5 trillion that is completely avoidable. A lot of it is waste and inefficiency, and quite frankly, a lot of profiteering. And we need to figure out a way to eliminate profiteering and make the soundest investment of those dollars. And that's where the single payer discussion comes in, is how do we make a better use of those dollars. Secondly is that the aging of the population, I'm a baby boomer, so I'm part of the challenge, that in 2030 we will finish completing our doubling cycle, and there will be 78 million Americans who will be over 65. And there's fewer and fewer workers paying into these social programs. As you know, Medicare, Social Security, and a lot of these social programs are income transfer. Those who are working today are paying for those who are receiving today. There's no magic bank account that we get to benefit from when we retire. So we need to start planning for these changes now rather than making decisions out of crisis mode in the years to come. And that leads to the fourth bullet here, which is in just 6 to 7 years, the CMS Office of the Actuary estimates that we're going to nearly double what we're spending on healthcare at the current expenditure trends. And that's despite the ACA, which had an intent to try to control costs, but it obviously has not. And the Medicare Part A in particular, at the current utilization rate, is scheduled to go bankrupt in 2026. Obviously, it won't go bankrupt. What we're going to see is draconian cuts to hospitals and physicians, almost bringing Medicare payment levels to Medi-Cal levels. And you know how hard that is to serve Medi-Cal patients at those dollars. So clearly we have our work cut out for us, and hopefully the engagement that is happening through the election process will educate Americans about how important this is. We can't keep kicking the can down the road anymore. Another big factor, perhaps those of you who are clinicians are seeing this with your patients, the average American household in 2018 spent over $2,500 out of pocket for healthcare, even when they have insurance. And the National Center for Economic Studies calculates that in 2018, over half of American families had less than $400 in the bank, which means that they're maxing out their credit cards, they're borrowing money, they're using money for rent to pay for healthcare, and it's just not a good setup for a solution long term. It's going to really devastate middle America. So we have to also be concerned about them. And if you hear about the debates from President Trump's administration, is these are the folks they point to who are saying ACA or Obamacare didn't do anything for me. If anything, it made things worse because I'm spending more money today than I ever did. And that doesn't, the $2,500 doesn't include the employee contribution towards premiums that employers are asking them to make. So it means more taxes, yes. Could it mean lower payments to providers? Yes. Could it mean fewer services for patients? Yes. It could be all of the above. Those are the typical solutions that we come up with at the congressional and state levels. And so our job is, can we find some alternatives now, and in particular, begin designing the workforce that will lead to transformation of our healthcare system to a more cost-effective system of care. So this stuff from our the Commission on Future Health Workforce. There's 7 million Californians who live in health profession shortage areas. So as you know, HPSAs are designated where they have less than one primary care physician for every 3,000 patients. Sometimes it's, in some areas, it's as much as one physician for 4,000 or 5,000 individuals. Clearly not enough access, just purely on the physician side. And then two is that 1 million persons need in-home supportive services, and with the aging of our population, that number goes up to 1.5 million by 2030. So we have a shortage of 4,700 primary care clinicians, not just physicians, but clinicians, to serve those 7 million that live in underserved areas, plus begin to replace those who are retiring. But we really need as many as 10,000 to completely transform the delivery system. Those of you who work on patient-centered medical homes understand that the new productivity is not how many patients we see, but what we do for the few patients that is really of value to them. So if we're set up to see 40 patients a day, and a patient shows up with a sore throat and she needs a pap smear and a mammogram, there's very little incentive for us to actually say, you know what, let's take advantage of the fact that she's already here. She may have taken a day off from work where she doesn't get paid because she took the day off from work. Let's provide that value to her, because our pressure is that we got patients waiting that we're going to have to see in a rush fashion. We need to redesign our system, and this is where physicians working with PAs, nurse practitioners, and other health professionals is going to be of critical importance so that we can still provide access to large populations. We're really in a shortage with behavioral health, and if we look at the frailty of Californians, we will easily need about 600,000 in-home supportive service workers. So there's opportunities for laypersons to begin their own lifelong learning and their own career ladder by offering them jobs in the home, because many patients default into nursing homes simply because they don't have the support at home. And we all know that very few nursing homes provide quality care. In fact, when we're in the hospital, we're taking disasters that are coming from nursing homes with septic patients. You wonder who's actually taking care of them. So what did we learn from the ACA, particularly their own workforce? So one of the things we used to teach our residents, there's really 4 domains in the ACA that are actually helpful to understand and develop a framework for a workforce. One is that the goal of the ACA was to achieve universal coverage. Clearly that was not possible because of the politics of the undocumented and other marginalized populations. So the next best thing was to also include $11 billion to improve access. So if not universal coverage, at least universal access, by doubling and perhaps tripling the number of FQHCs and rural health centers across the country, and we had pretty good success with that. There are also insurance reforms, most notably the Health Insurance Exchange, which covered California as an example. And then there are also delivery system redesign. And this is something that Congress put a lot of value on, which was, it's one thing to get universal coverage, but if we're just giving people access to the same old system of care, it's not going to do anything to reduce unnecessary costs and waste and inefficiency. So there's incentives to transform healthcare. So those of you who may be working on PCMH, accountable care organizations, those are all components of beginning to align physicians, hospitals, and other institutions to provide more cost-effective care. But it also entails the kind of competencies and the type of workforce that we need. So I'm going to spend the rest of the time talking about that. And obviously technology as an enabler is really important. I won't spend too much time on payment innovation because time doesn't allow, but maybe in Q&A we can talk about that as well. So when we look at education and the role of physicians, and again, we recognize other clinicians are equally important, we need to understand sort of where we are as stakeholders and what key role we could play in transformation of healthcare. So when we look at where we spend our dollars, our $3.5 trillion, 20% goes to physicians and advanced practice clinicians, those PAs, nurse practitioners, et cetera. 3/4 of that 20% goes to specialty care. And if you look at successful systems like Kaiser, Permanente, Group Health Cooperative, Harvard Pilgrim, and others, they've achieved a balance of 50-50 primary care with specialty, truly believing and putting their money where their mouth is, that the ounce of prevention is worth the pound of cure. And Kaiser's record profits, I think, are a big proof of that concept. Hospitals, by far, are the largest ticket item in healthcare, roughly around 40% of the healthcare dollars. And the Dartmouth Atlas folks, Dartmouth Institute, and also Brookings in Washington, D.C., have done separate studies where they estimate that probably a third of all hospitalizations are completely avoidable or preventable. Kaiser's model has already figured out how to reduce that by half. So you look at their ledger, 20% of their dollars go to hospital care, not 40%, because they move stuff to outpatient, ambulatory surgery instead of inpatient surgery, urgent care instead of ER, freestanding diagnostics and labs, et cetera, as opposed to inpatient-oriented costs. So we have something to learn from. It's no longer a theoretical framework about where we can save. We have something to learn from, and how the workforce relates to that is critical. Nursing homes, 10%, probably would be more, but we do have a moratorium on licensing new beds for the very reason that they don't really provide the kind of care patients need. And pharma and technology is 12% right now, and doubling every 3 to 5 years. So this is what's also of concern, not only to Medicare and Medicaid, but also to commercial plans, because since they're dealing with a smaller denominator of dollars coming in, because generally they're insuring healthier populations, it's about 25% of their ledger is pharmaceuticals and technology. And you know, a lot of attention has to be paid to the monopolies that pharmaceutical companies have, and identify ways to engage them in better value for consumers. And then public health, you can see how little we invest in public health and prevention. We really have our world upside down in many ways. But the key here in all of this is that physicians and advanced practice clinicians control 80% of the healthcare dollars, because we decide who gets admitted to that 40% of the ledger. We decide what kind of treatments are offered, what kind of technology is used. So clinicians are critical in terms of transforming healthcare and how we train them, not only to be excellent at the clinical skills that they have, but also to be excellent at leadership and to transform the healthcare system through the experience that they have and the knowledge they have. And many medical schools are now adopting the health system science philosophy, which is now there's a third anchor to medical education. There's basic science, there's clinical, and now health system science. And I've had a chance to work with the Kaiser folks, Dr. Schuster and his team, on designing their health system science curriculum for the new medical school. So they clearly believe in all of this themselves. Just a quick comment here. If you're interested, you'll get a copy of this presentation using a lot of Barbara Starfield's work at Johns Hopkins before she passed away, family physician that showed the value of primary care and where it reduced unnecessary costs, as well as the fact that technology is a key ingredient of that high-performing primary care. So there's been some progress to date. On the primary care redesign, we now have NCQA and in particularly the Joint Commission certifying patient-centered medical homes. We also have access through technology. In particular, Kaiser reported that in 2015, throughout their entire system, they had 110 million visits in 2015, and 52% were virtual. So that's about 55 million visits that did not need to be face-to-face, tying up the clinician's time so that they could actually spend more time with someone else. And 2/3 of those visits were provided by non-physicians. So this is clearly an evidence that technology will be our friend in terms of improving access to care in multiple ways. Davis has a similar thing, and then Amazon Care, with their partnership with Oasis in Washington, is estimating that they will be doing virtual visits to the tune of 70% of the visits for Amazon employees. And then there's ACOs and the CMMI practice transformation networks. All of this is progress. We're actually getting not only education at the undergraduate level, education at the graduate medical education level, but also the continuing medical education and maintenance of certification starting to merge together, which is really a beautiful thing. When we started our residency program, our mentor, Dr. Sanford Bloom, who really taught us how to run a residency program, used to joke that residency gave us 3 years to undo the damage of medical school. But he was being provocative, of course, but had some truth in it that we need to integrate how we work together from the medical students forward. And I would argue how we work with our pre-meds and college students, giving them meaningful education that strengthens their CV and their application to medical school, but gives them a knowledge base that they're going to need to become better clinicians. ACOs, you're probably familiar with those. The key here is the last bullet, that the Government Accountability Office did an evaluation of the first cycle of ACOs, and they found the most successful were the physician-led ACOs. They actually went as far as to say that hospital-led ACOs did nothing more than just reconfigure dollars to continue to subsidize the inefficiency of hospitals. So, clearly a strong statement about physician, clinician-led initiatives. This is a diagram that just describes the ACOs, but let me kind of go forward so we can get to some of the educational pieces. I did want to talk about Kaiser as a model, and Kaiser is not perfect. I trained at Kaiser. I was a partner for 5 years, but 6 of us left to start our medical group in East Los Angeles for the very reason that as good as Kaiser is, it struggles with Medi-Cal patients and it struggles with the uninsured. And our mission when we chose to go to medical school was exactly to serve those patients. And in fact, families don't come to us with neat little packages where they're all covered with the same insurance. The worker may have commercial, the spouse and the children may have Medi-Cal, and if we don't do a good job of uniting them under one roof, we're actually discombobulating the care that they get as a family. So for us, we used everything Kaiser taught us to do what Kaiser does well, which is population health, managing financial risk, understanding the value of technology and the distribution of primary care and specialty care. But we also decided we needed to do something more than what Kaiser did. But there are some important lessons here. So Kaiser, as a health plan, has a single medical group, one in Northern California, one in Southern California. And what they look at is both their medical group and their hospitals are cost centers. So they're not there to have all the bells and whistles to make lots of money. They're there to do the best job possible for Kaiser members. So unlike our hospital at White and others in the Los Angeles County community, they have 14 hospitals to serve 6 different counties, from Ventura all the way down to San Diego. It's about 4.5 million members. The rest of us are asking our hospitals to make a living out of a very small number of patients, which means we're going to rely on admitting patients that don't need to be admitted in order to fill beds that keep the hospital profitable. That's the reality. That's something where they eat our lunch, because they've been able to reduce that 40% to 20% of their ledger simply by saying we're going to make the most judicious use of hospitals and we're going to move as much as we can to the outpatient setting as possible. The second thing is that the medical group is an integrated medical group, also cost center. So they are challenged with negotiating with Kaiser Health Plan every 2 years a lump sum payment so they can pay their physicians well. And what they have found is that they're able to pay their doctors better because they use those savings, they use the savings from the hospital side and push it over to the physicians. So we go back to that earlier comment that the folks at Dartmouth and the Brookings Institute say that we're wasting basically $800 billion to $1 trillion every year. Imagine if we put those $800 billion or those $1 trillion in the hands of clinicians who understand what their patients need, who understand how to work together as an SCTMG, but in this case for the poor, the indigent, the Medi-Cal, and be able to provide Kaiser excellence to those populations, which is where Kaiser struggled. And that really is the formula for network model health plans to leapfrog past Kaiser, do everything that Kaiser does. Because eventually we're going to get the single payer. That burning platform has no other outlet except a single payer solution. So that's a good case study for ACOs. It's a prepaid ACO, but it shows you how they work. So a little bit of the work on our commission. So the commission's charge was to try to find a strategic plan for the next 10 years, 2020 to 2030, to try to get the needle moved just right to the number of clinicians that we need to serve Californians, 4,700 shortage of primary care clinicians in those really underserved areas, but a total of 10,000 additional clinicians needed for transformation of healthcare, and to agree on a comparative and a cooperative agreement between community colleges, Cal State, and UC. There's so much bigotry between the UC and the community colleges that if you want to be a physician, you go to a community college, you go to Cal State, you got to go through extra hoops just to be considered for admission. And that shouldn't be. These are all publicly supported institutions. The other thing is that community colleges are the portal for underrepresented minority students. That's where we tend to find the critical number of young people who aspire to be clinicians who will provide the kind of care that people need when they're looking for someone who relates to them culturally, linguistically, and experientially. And so those are the key ingredients for what the commission decided to do. And then looking at leveraging existing and new resources. So part of the good news for us as educators is the state is mobilizing dollars towards education, as long as we adhere to this new philosophy of a new workforce, a new distribution, new competencies. And secondly, private institutions like the California Healthcare Foundation, the Wellness Foundation, Endowment are going to put millions of dollars into this initiative. So worthwhile for us to consider opportunities for us. The way we divided the work of the commission was 3 subcommittees. I was the co-chair of the Primary Care and Prevention subcommittee. There was a behavioral health and a healthy aging and care of the older adult. This is the way we try to break up the responsibility, but we synthesized all of them in the entire report. This is a busy slide, and you'll get a copy, but it's suffice to say that we made 27 recommendations, 10 being high priority. The first 4 are related to pipeline. How do we support young people who want to be clinicians, who want to have a meaningful career in underserved? So the first 4 are related to pipeline. So those of you who work with pipeline programs, there's resources to be able to do this. The next 4 are related to modifying and modernizing medical education, building on the success of the UC Prime programs, but also including private universities like Loma Linda, USC, others who are doing important work in this area to provide them with the resources to also transform their curriculum around these types of models. And then the last are related to these paraprofessionals, which are basically new entry-level positions, starting with what we called as the commission, universal home health workers, that become kind of the pluripotential stem cell to go on to other careers as they continue their own lifelong learning. Altogether, there were 27 recommendations. The total cost is about $300 million a year. It's a big chunk of dollars. But the good news is 2 parts. That it only represents less than 0.1% what we already spend on healthcare in California. And it's a very simple thing. As an employer, we have 150 employees in our medical group and IPA. And if somebody came to me and said, for every $100 you pay for healthcare, would you contribute 10 cents towards workforce? I would say absolutely yes. If we make that argument to employers and other payers, I think that they would also agree with that concept. The second thing is we're spending a lot of money that's wasted. So this is a better use of those dollars. And this is what the governor is going to be working on. He is completely aligned with the recommendations of the commission. And then the last thing really is that the $300 million will be smart investments because we're already investing about half of that money through existing programs that I'll share in a second. Altogether, we would expect by 2030, 40,000 new health workers, including some of the really critically needed MSWs, LCSWs, others marriage and family therapists, et cetera, as well as the paraprofessionals like community health workers, promotores, and universal home health workers. But also creating new residency programs, because we're seeing, thankfully, an expansion of medical schools, but we haven't seen too much of an expansion in residency. So the teaching health center model and the new expansion of existing residencies is going to be critical. And I'll show you some of the initiatives the governor is supporting to do that. So one is we have state loan repayment programs. They have been really good at encouraging physicians and other clinicians to stay in underserved areas and to even stay in with academic practices so that they can begin to teach others and recruit others into the field. Some of them have already existed. The Steve Thompson National Health Service Corps Cooperative Agreement, which is another state loan repayment program, partnered with the National Health Service Corps. And something new through tobacco tax is CalMed Force, which is $40 million, brand new $40 million, started last year towards GME in California, with some priority counties, particularly the Inland Empire and along the Central Valley. There's also an LA County specific initiative by LA Care, and here the Inland Empire has its own network enhancement program to support recruitment of physicians to underserved areas. And the governor is investing, starting in 2020, $70 million over the next 5 years for behavioral health worker training and expansion of the medical school at UC Riverside, and now there's money allocated for UC Merced as well. And on the GME side, we've had Song Brown through the Office of Statewide Health Planning, now CalMed Force, Route 56, also has GME training, and LA Care is investing. And something you may be familiar with is the state plan amendment proposal is going to come through the Medi-Cal waiver, roughly $900 million to support 16 counties with public hospitals and partner institutions to expand residency training. So this is brand new money that will come through the Medi-Cal waiver. Very important. This is all supported by the governor, understanding that this commission's report needs to be activated through funding. So what does that mean for us? Our academic medical centers are a jewel, not because I'm here at Linda, but you guys are a jewel that's always excelled at developing curriculum, and I'll show you some examples of what has been adopted across the country that started in academic medical centers. But we need to do a better job of streamlining the undergraduate medical education, GME, CME, and maintenance of certification, and also welcoming our other health professional colleagues into a united front to provide the kind of workforce which is patient-centered, but also team-oriented, and distributing the workload among people so that everyone gets to do the best job for what they're trained to do, working at the top of their license, or in the case of paraprofessionals, working at the top of their training. So many of you may be familiar with the health system science. This was an AMA initiative called Accelerating Change in Undergraduate Medical Education. Funded 11 medical schools to develop new curricula around that third anchor to accompany basic science, clinical training, now health system science. This is something that the four foundations, California Healthcare Foundation, the Endowment, Wellness Foundation, and Blue Shield Foundation are very interested in funding medical schools to do more of that here in California. ACGME, with its 6 competencies adopted in 1999, and now with the new sponsoring institution requirements, those of you who are in GME are already dealing with this stuff, it's also about the integration of undergraduate medical education along with graduate medical education and other disciplines besides just physicians. 8 themes, very similar to health system science, very similar to what America needs and California certainly needs. And now ACCME is also involved in that collaboration. So fortunately, as we all work to continuing education, maintenance of certification, certificates of added qualification, there's now a streamlined vision for uniting all of these entities. So there's little redundancy and more efficiency paid to health system science education so that health professionals understand their role to lead transformation of healthcare. So this is a credit to teaching institutions, particularly the academic medical centers across the country, which is now being adopted throughout acute care hospitals that are not necessarily affiliated with teaching institutions. Very familiar to you, intensivists running intensive care or adult special care, children's special care, et cetera. Hospitalists increasing and improving the efficiency of work in the hospital. Nocturnists, making sure that patients are now covered 24/7 with equal intensity. proceduralists to make sure there's no delays in the procedures, and particularly access for patients that need emergency dialysis, etc. And even long-term care, the SNF and the extensivist model, making sure that we're treating patients as aggressively and as intensively in those settings as we would when they were in the hospital. And that improves the outcomes and reduces the likelihood that patients will stay in those settings forever. And work needs to be done on the ambulatory care side, and particularly in-home supportive services. So starting to see the patient-centered medical home diversified into home health services. So maybe we may see homists in the future, or at least LA is homies. Because and we're already seeing telemedicine, physicians actually doing visits in the home. So transformation of medical education is achieving a balance between primary and specialty care, not physician-centric. Maybe physician-led because of the training that we have. When we looked at this in the commission, the average physician in primary care spends 16,000 hours in medical school and in residency training to be able to be a proficient practitioner in their discipline. And, not to demean the work that nurse practitioners or PAs do, but their training is much less intensive. It's about 6,000 to 8,000 hours. And those extra hours mean significantly for the transformation of our healthcare system. There is no substitute for those of you who have done residency, when you know you're sitting by the bedside for 24-hour shifts, and you're taking care of critically ill patients, and you're making treatment decisions, and you get to see instantly whether that treatment decision benefits or not. It starts to teach you about futility of care and more cost-effective use of new technologies. It starts to teach you about what we need to take to the outpatient setting in order to improve and prevent the need for those services to begin with. And that's why physician-led but not physician-centric is something that we need to consider. Obviously, we teach nurse practitioners and PAs, and some of our best teachers are nurse practitioners and PAs, because as lifelong learners, they catch up to us pretty quick. So it's when we're finished with our training that there's an inequality in the training, but over time they become just as proficient as we do. And so let's not forget that everyone gets to work at the top of their license eventually. So that's a key thing about the transformation. So in specifics, it's developing physician leadership, making sure that we are accountable as teaching institutions for the specialty and geographic distribution of the workforce. We can no longer point and say it's someone else's responsibility to turn out more primary care doctors or to increase the diversity of the workforce. That's the responsibility we all have. 3 is the practice transformation, is understanding that the cottage industry that many of us were trained in my generation is no longer useful. Maybe in rural communities where there's no other choice, the solo practitioner is still something that survives. But in the urban areas, suburban areas, we need to find a way to become more Kaiser-like, but excel at what Kaiser struggles with, which is the care of the poor, because there will always be poor people. The other part of that is obviously using quality and the whole idea of value, understanding what that means. It's not cutting corners, but using the most cost-effective delivery of services to benefit patients, truly patient-centered, community-centered, as well as understanding our role outside of the 4 walls of our office and how important that is. Number 4 is the interdisciplinary education and training. We all have a lot that we can learn from each other, so let's not miss that opportunity. Patient, family, and community engagement is critical. There has to be a role of engaged patients. Too many times we take the shortcut and say patients are non-compliant because we never give them the tools in a way that they can use them, whether it's linguistically, affordability, etc. But there are opportunities for us to engage our patients more, and that means that they become partners. They become the most important member of the healthcare team. It's the patient who can teach us a lot about how to serve them better. Technology is our friend. Not only right now that we're going through the pains of EMR, but it's a transition. I tend to be a Pollyanna anyway, so I do see brighter days coming up on the EMR. You're all hearing about the new generation EMRs that are much more integrated and interoperable. I think that day is coming, especially better voice recognition so that we can actually just start dictating as we're examining the patient or interviewing them. Using telehealth and health information exchange for the improvement of the quality of care patients get no matter what setting they're getting it. And artificial intelligence so we continue to improve the services we provide. I was just looking at a model in Japan where they had the challenge of the elderly population and very few young people to take care of them. They're actually importing immigrants to provide some of the in-home supportive services, but they're also using technology. They've gone away from nursing homes to room and board settings where they have, it's almost like a little hospital unit. They have a single worker instead of one-to-one, is one worker for every 6 clients. The clients sleep in a mechanical bed, which automatically becomes a wheelchair. And the hallways are wide enough for that wheelchair to help them be mobile. The elevator is big enough to accommodate the wheelchair so that they can go out into the community. And more importantly, they're using artificial intelligence. Those beds are programmed to record how quickly a patient can get out of bed. And if it starts to change where they're getting weaker, it starts to put out red flags for the clinicians to begin assessing the patient. Those of you who are familiar with the PACE programs for the elderly are very similar. They're still very labor intensive, but they also are conducive to using technology. So lots of good news. Robotics, of course, is here and a very effective way to deliver care. And lastly, the 2 parts here, how does value-based practice differ from what we do now? And I gave a talk at Altamed. They're a large FQHC in Los Angeles, and they're moving from volume to value. Because those of you who work with FQHCs know that the business model they have is face-to-face visits, because that's the only way they get paid. And they're trying to move away from that to more remote monitoring of patients. So I looked at their data. They have over 1 million visits a year, and they average about $200 per visit for their prospective payment. So that's $200 million in the bank automatically every single year. And their CFO is telling the clinicians, you got to see more patients because we got to stay ahead of the costs. You got to see 1.2 million visits. And I went and gave the talk and said, no, maybe you need to see 700,000 visits so that your clinicians can actually give those patients one-stop shopping. And I could see the CFO kind of getting apoplectic because I was saying the wrong thing. But the reality is, if they really want to go from volume to value, that is exactly what has to happen. We have to transform the way we deliver care and enable clinicians to do what they do best. Remember those, for you who are physicians, you know, those 3-hour H&Ps we used to do as medical students? Well, we don't need to spend 3 hours, but quality time with the patient is critical. And every hour we spend on front saves us 100 hours of angry patients, angry family, or a poorly served patient because we didn't take the time up front. That's part of the transformation that needs to happen. And lastly is maybe we should be preparing for Medicare for all. And personally, this is where I disagree with Bernie Sanders and Elizabeth Warren, is that we cannot do away with the health plans. They serve a really critical role in terms of population health, the IT systems we need to track care, quality and cost. And if we remove them from the formula, we're going to have to reinvent, and we may not do it as well as they do. So, full disclosure, I'm on the Blue Shield board, but I also believe, the reason I joined the Blue Shield board is I believe that health plans have an important role to play in the transformation. So my preference would be Medicare Advantage for all. I don't know of any health plan that doesn't make money on Medicare. I don't know of any physician who doesn't want to accept Medicare. I don't know of any hospital that doesn't want to accept Medicare, and certainly patients like their Medicare. And it also helps that a billionaire like Warren Buffett is a Medicare recipient, because people like that will always defend Medicare to prevent it from becoming a Medi-Cal where they're ratcheting down the payments. So a lot for us to consider, but I think it's an exciting time to be in medical education because we will get to drive the changes, starting with that stem cell that is becoming pluripotential and starting to decide what they want to become. We will help them embark on that journey so they can be the most successful as possible. So thank you very much.